So here is lady's question in the back. Where a man would inject would be anywhere in the side of the penis, in the entire shaft. So if this was my penis, and I honestly don't have one.
Oh, you're gonna say that to all of them.
I'll just put the mic down for a second.
Your poor husband.
I know my poor husband. He says, I don't want to hear about it. He's just so shy. We're totally opposite. Anywhere from the base to mid-shaft, along the sides. So you stay away. You stay away from the tip, the head or the glands. You stay away from underneath or on top. So underneath is where the urethra is. On top is where the nerves, the blood vessels are. So if you go in the side zones, you're in the right area. Okay? It takes practice. And we always tell patients to rotate the sites. Don't always put it in the same location. So technique is very important. You inject it, put your medication in, and then I tell patients, make sure that you compress firm pressure on it for 5 minutes after the shot. So it helps the medicine absorb and it helps prevent any curvature or scar tissue. You will find that sometimes the injections, if you go to blogs on the internet, there are guys that will blog about these things, and I have read some of these blogs. Healingwell.com is one blog that I've seen, and patients actually find us on healingwell.com. And there was some blogs that I read that said these injections are a crapshoot. One day they work, one day they don't. And that's very true. I tell patients, one dose, don't depend on one dose to know exactly the full story. You need to gradually go up on your dose. So for instance, in the syringe I passed around, it's a 30-unit syringe. You might have to go all the way up to 100 units. They have syringes that go up to 100 units. So don't be afraid to go up on your dose. And I tell them to go between 5 to 10 units per dose, work their way up to see what's an effective response. Because I certainly don't want to be putting them in the emergency room with what's called a priapism, a 3-hour erection that's not going down. And if you ever use injections, I always tell my patients, don't ignore the erection that's staying up. Yeah, it's going to be fun for a while, but then after it's a little embarrassing, and then eventually we got to get the old blood that's accumulated in the penile shaft, we got to get it out and recirculate it with fresh blood. So it's something very, very important. More hours that go by, if you develop this condition, you're doing more harm to your tissues, and you could develop permanent impotence. So you have to be careful and you have to be smart. And if you ever are in a situation that you are getting an erection, it won't go down, Sudafed, the cold medication, is something that is a first-line medication that we tell patients to take just in case it won't go down. If you don't have any existing heart problems, it can raise your blood pressure and still harden your heart. But I do tell patients to have it on hand if they can take it safely.
So,
yes,
you're saying because you don't get the same reaction every time from the same dose, you need to test each dose a number of times.
Yes, well, yeah, in terms of the dosing question, I would tell a patient like who I've discharged after the catheter removes, take 3 days a week. You can't inject more than 3 days a week. And make yourself a little chart. And chart how much you gave yourself and what location. Because you're going to forget what your last dose was. And do it 3 times that week, but you're going up 5 units each time until you know what an effective dose is. So once you say, okay, 40 units is really where I get a really good, reasonable, normal-like reaction that is firm enough for intercourse, they're going to stay at that dose. But then they might be disappointed on another day to give themselves 40 units in another location, and it just wasn't the right, it didn't work as well, or they're disappointed. And I have had some patients that said on one side of the penis works better than the other. So there's some men that have more blood flow on one side than the other. So that's why making a graph with your responses and how well it's working for you is nice for you to look back at and just to keep, because you might forget.
Scientific experiment.
It's a scientific experiment. But I tell patients, don't despair. If you find that you're going up to 100 units and it's not that effective, it's okay. Call me, because there's other compounding. I call them our love potions. There's different love potions to put you on. So if love potion number 1 didn't do the trick, you're going to love potion number 5 maybe. I don't know. Love potion number 9. Yeah. So auto-injectors are available. There's those guys that just want to do this, but oh, they get too sweaty with a needle and the thought of it. So there's these devices that you can actually put your syringe and hide the needle. Inject DS and Auto-Eject, so if you want to move that. So Eject DS is on the left, or this whole thing. I don't know if you've heard of it, but it's a company from California called AmbiMed. And AmbiMed makes this, you load the syringe, and what happens is the needle is hidden under this white plastic part, and you put the needle up to your skin, and you push the trigger button, which is here on the side. You can see it over here. You push the trigger button, the needle goes in, and then you just push the fluid in with the handle, or the plunger. So I like that because if patients are using high dosages of this stuff, you don't want, for the next slide, there's Auto-Eject 2, which does both. That's a company from the UK, and I'm trying to think the name of the company. Anyways, from the UK, if you Googled Auto-Eject 2, it delivers the needle, and it also delivers the solution, so you don't have to worry about it. But I do have some patients that have pain with the medication that's injected. And if it's painful, having this injector that's pushing it in all too quickly might not help. So it depends on you, and it depends on your dose and what you're using. Those are just out there. You can order them both online. So I tell the patients inject 2 to 3 times per week, alternating sites, avoiding any veins and applying pressure for 5 minutes. I tell them to tailor their dose like I just talked about, but I don't want the erection lasting longer than an hour to an hour and a half. Okay? It should be naturally getting out of their system and coming down naturally. Sudafed's on hand just in case. We actually would tell a patient to take 120 milligrams of Sudafed, which is quite a bit. But again, if you have heart problems, I always tell patients check with their primary care doctor because they wouldn't want your blood pressure going sky high to do this. Yes, sir.
What is it about the Sudafed that lowers it?
The Sudafed has what it would be an antidote. So the medication helps with dilation. This helps with contraction. So it's got properties that's going to constrict blood vessels. Okay, to help get the blood out of the penis. Send it back into the circulation. And then I tell patients don't ignore going to an ER, finding a urologist for any erection that's longer than 3 hours. Products are used temporarily until the nerves respond. So I always tell patients, if you didn't have any pre-existing erectile dysfunction issues, you can expect that you'll probably be weaning off these therapies over 1 to 2 years as your natural erections return. So when you're waking up in the morning or when you're getting excited and you notice that you're getting some spontaneous erections back, that's a good time to start experimenting with high doses of Viagra or Cialis or even Levitra. Levitra's more the weaker ones. But it's time that when you're seeing signals that things are starting to work, you want to challenge your body with just the oral medications to see if you can wean yourself off of all these other things that you're using. Okay. But in the reality is that the men that we treat in the age population of 50s, 60s, 70s, even 40s, these patients have maybe had some pre-existing erectile dysfunction to begin with. Usually physical, comorbid problems like hypertension, aging, diabetes. They might be smokers. They might have some other inorganic problems in their psyche. So there's different types of impotence, but normally in the aging population, it's more of an organic problem, but you can have an inorganic problem, which is more of a psycho-emotional factors that are playing into the scenario, like anxiety, depression, or relationship issues, etc. So there's a way that urologists would differentiate maybe what's what, but usually if you've had treatment for prostate cancer, most of it is certainly going to be a physical response. It doesn't have anything to do with you mentally. It's because of the nerves that have been damaged. So the benefits that I see, as I was making these slides, I was thinking, what are the benefits to these patients? So why would my program be so successful in what we've developed at Henry Ford? As I see it, and maybe you can think of more, but it allows patients more control over their intimacy and sexual function earlier rather than waiting until natural function returns and preventing frustration with ongoing ED or erectile dysfunction. It assists in preventing penile atrophy and or fibrosis from developing. Again, I don't know, or urologists don't know what the superior protocol is because not enough research has been done yet, but maybe that will come down the line. It assists, sets realistic expectations early to avoid confusion and or disappointment, okay? And partner involvement, your partners are involved, and sometimes guys are needle phobic and their partner will inject for them. Sometimes if they're using a vacuum pump, they'll use it as a combined therapy, getting both involved. And then the patient chooses. When I run these classes and I demonstrate the use and we demonstrate the pumps and we demonstrate the injections, the patients will say, well, that appeals to me more than this, and so forth. So the patient chooses and drives their own program. So when I first started doing this program locally, of course I started at Henry Ford, and then I wanted to move it to my community to help people within my community. So I thought, well, where could I hold this? Who would host something like this? Where could I get a venue that would put up with me pulling a rubber penis out of my purse and showing how to do injections? I mean, it had to be clean, but yet professional. So clinical versus non-clinical sites. So initially, I started doing some talks at the non-clinical site, which was more hospice. So as I got to thinking, I thought, I don't want this to be something, I love hospice, and I think that's a beautiful organization, but I wanted to keep it in a uplifting, educational environment where treatments were given and not so much associated with loss of life and termination of life and so forth. So we now just moved it to Metropolitan Hospital, Windsor Regional Metropolitan Campus. So I networked with the local urologists, Dr. Sorensen, Dr. Deckley, Dr. Goyle, and I met Dr. Sorensen for one morning, and he called me a Mennonite. And he didn't hurt my feelings though, but he agreed that we should start doing something in Windsor. So we worked with the public relations department, and voila, I've got this thing going on once a month at Met, which I'm now in couples over once a month. I figure I'll do it once a month because with my full-time job, I didn't want to get too busy. So, I'll do it once a month, Wednesday evenings, 5:30 to 7:30, and it's not restricted to location. If there's any patients that want to travel to these classes and come, you're more than welcome. And it's posted usually on some of these prostate cancer websites, like our local one, and I think Jerry has my latest flyer as well. I have another meeting coming up in December. I just had one Wednesday this week. Gaining urologist support or radiation oncologist support is essential in developing a program like that. Finding the right person to deliver a program like this. So like I said, I've got a lot of work to do because I want to start training and getting people and nurses involved in more of this. And just like there's diabetic educators out there, why shouldn't there be people doing this more often? So I think it's just as important. And then I'm still kind of battling, fee for service back and forth. There's a big part of me that believes in community service, which I have been doing. But at some point, I'm certainly thinking about maybe going into individual consultations and so forth with couples. I find that patients usually like to sit in a group format, and initially they come into the classes and they sit there all reserved and not knowing what to expect. By the end of the class, they're all getting to know one another and communicating and talking about their experiences, and it's generally a comfortable environment. But I do get some couples that are more reserved. So I was thinking I should start doing something either through FaceTime, Skype, or telephone consultations for those more reserved people. So I think fee for service eventually I'll probably get to that level. I'm still battling with that. So an example, one of the surveys that my Henry Ford patient had written, and I saved this because I thought it was so true. My husband and I are so thankful for the encouragement and educational videos, seminars, and materials that your team has provided for us. Our only regret is that we weren't referred to Henry Ford many years ago for ED. Can you educate more urologists to be more proactive? And thus, that's why I'm taking it to Windsor, and I'll take it wherever I need to take it to get this message across for quality of life for you guys. And I love quotes. Robin Williams, see, the problem is that God gives men a brain and a penis and only enough blood to run one at a time. Very true. And then this one, I like this one. Urology humor. I am a broccoli and I look like a tree. I am a walnut and I look like a brain. I am a mushroom and I hate this game. So if I work around, I think because I've been in urology so long, the reason is because I work with fabulous people. All urologists seem to have a fabulous personality, and we have a large group of them and the staff, and there's not much turnover in our clinic because we really enjoy what we do. So Thank you very much.